Welcome to Treating TMJ, a journey to a pain-free life.
Welcome to the TMJ and Sleep Center podcast. I'm Randy Hawk, along with Dr. Insolera. Now, our last episode, we talked quite a bit about symptoms and cause and effect and understanding the difference between treating the symptoms instead of addressing the problem. So once people make that decision, okay, I think I need to go see Dr. Insolera. Let's get in today. On this podcast, I'd like to get into what to expect the minute they call and from getting the appointment to going through their first consultation.
Well, we were talking about the Cure Consult consultation, and that gives them an idea if this is something they want to follow through with. And if they do, then the next step would be a new patient exam. So what we're doing in the new patient exam is creating facts where before we're kind of using opinion, but now we're doing facts. So we're going to do tomograms of each joint, which give us positive location of where the TM joint condyle is to the skull. And that's a big deal because as the jaw progresses is further back and up into the skull. Okay, so back and up into the skull, it creates compression, undue compression. It can even compress your ears where you might feel pain and pressure by your ears, and possibly even fluid. And a lot of times it's TM joint fluid that can get pushed into the ears. But it's all based also on bite. So as your teeth come together, that positions the jaw in this adverse position. So we'll see that on a tomogram. So that's kind of like, okay, we see it. There's a fact. The jaws are in kind of the wrong place. We can also factually look on muscles, and we do a clinical palpation of about 40 muscles of the head and neck, and we're looking at posture as well. So we're tying everything together. What I want the patient to know is we're not treating them just by their jaw or just by something simple that wouldn't work like a splint, because that wouldn't work. We're working with a measured neuromuscular orthotic that's based on EMG, neuromuscular measure, cross-indexed to a tomography, X-ray that you'll see the before and after condyle position in the skull based on when you bite into an orthotic position. That will change the location of where the condyle is. That's internally, or we might say intracapsular. Okay, I don't want to get too fancy with words, but the way to look at this is because the jaw is too far back in the joint capsule, the muscles attaching to that jaw have to be too short, meaning their range of motion isn't the proper length. So if it's not the proper length, and you're doing this 5,000 times a day, and you're doing this since age 5, so you can see where this is going, because muscle's attached to bone. If you have unhappy muscle because you're not getting the right range of motion, it's going to take its wrath out on the bone. So basically, when we see bones, jaw bones, neck bones, whatever you want to see, we'll see the wrath of dysfunctional muscle, because it will create disc compression, it will create spurs, arthritic spurs, it will create joint remodeling, meaning the joint itself changes shape because it's been in a wrong place. And so everything has to compensate for the fact that there's an unstable bite position, and it continues to become unstable as the dysfunction multiplies over time 5,000 times a day.
Right. So the dysfunction is basically a chain reaction. And you used a bunch of terms that Dr. Insolera knows as a guy who's been through this process. For the listener, basically, it visualizes and measures where you are as the patient, where your jaw, where your neck, how strong your bite is, having us bite on tissue papers and things like that. But it really gives you a gauge of here's where you are. And also, you talked about this thing causes this thing, causes this thing, causes this thing.
Right.
You really figure out just how far in that chain reaction the person is when they walk into your office that day.
Yeah, really. You can see, because the older they are with this disease, obviously it just gets worse. So imagine if you were walking the street and you saw somebody kind of bent over walking. And I'm wondering, well, how the heck did that happen? Well, they didn't start like that, but they slowly got to that position through time. And because it was slow and it was through time, and it did happen when they were kids, symptomology generally doesn't necessarily have to be there all the time. But nevertheless, gravity, age, and dysfunction, muscle dysfunction, create all of the above. We can also see we have a nice CBCT, they call it X-ray, which shows the face. So you'll get what they call topography or facial look. But then we can take the skin off and look and see what's underneath and show you what's happening with the bones and and why you're here, in essence, and what the muscles have done to the bones.
And we'll definitely put examples of this on the page that this podcast is on, so people can check that out and know that. And one of the great things is when you see, like when I saw the pictures of my jaw and my face and things like that, and then you also have, here's a healthy one, and here's yours.
Well, if you
and that's where it starts to become real for you. Like you can visually see it, and you can say, now a normal bite should be. You would know the exact number, the measurement.
It's never. I couldn't give you an exact, but let's put it this way: it's down and forward from the capsule itself. If you think of a joint capsule as like a ball bearing, like your chair has rollers with little round things underneath. Okay, that's in a capsule, but it can't work very well if the capsule isn't smooth. But as your joints get worse and worse, the capsules aren't smooth anymore.
You get the bone spurs,
you get
the rough
the
edges.
irregularity, and we call it remodeling because it's changing shape. And when it changes shape and the muscles get more dysfunctional, they can be painful. So if you press here, that could hurt. If you press along the side of your jaw, that could hurt.
Right here.
Because so that's an inflammation of the joint. Well, we call it capsulitis. But if it was of your shoulder, a very familiar term, it's bursitis. Same thing, joint inflammation. Because of a malposed shoulder position and a malposed TM joint position.
So as a person's going through this with you at the TMJ and Sleep Center, every X-ray and measurement and thing that you do really starts to reveal what state their condition is in, and starts to outline the treatment plan.
Yeah. And I do like to talk, but there's another reason why I like to talk. I like to make perfectly clear to the patient what they're looking at, so they don't have, they can understand what I'm looking at, so that, and questions are always, it's fine with me. The more questions, the better. I just think the more questions you ask, and the more you observe and understand what we do, and the more I talk, the better we look, because we're not hiding a thing. It's all out in the open as to what this is what's going on. It's a process. It's a disease. It's a journey, and we want to stop that pathological journey.
And the models that you have, the bite models, and a lot of skulls, and
lots of cases.
Yeah,
30 years of cases. Yeah,
and that you can show, saying, okay, here's your table in the office has all of your examples that you use to help educate people in the process. Right.
Yeah. It's got some, and the rest are, put away. But no, but it illustrates what we're talking about. And we have X-rays, of course, that we would illustrate. And even prior patients, we don't have names on these X-rays, of course, but we show befores and afters. And it's quite graphic to see changes in the posture and the bite simultaneously. And that's how you cure people. That's how. But it only happens if the patient's cooperation is where it should be. I emphasize that really strongly, because if you are at our place, I know what my job is, and that's to get rid of why you're here, okay? And I just believe everybody has to work to the same level. So I expect my patients to work to the same level.
And that's a big difference. And I've been on the receiving end of your accountability, and I've seen you with it with other people. And it's important. It's a light bulb moment. You understand that you are an active participant. My dad used to always say, Randy, you got to be active in your own rescue. And it's
you said that last week.
Yeah, it's definitely like that was for me. I'm like, I have to be active in my own rescue on this. If I want this to stop.
I really like that phrase.
I can't just expect. And I do think that's different, right? A lot of people are like, I'm going to the doctor today and I want a shot or a pill or something that fixes this immediately so I can go back to my life. And that's they mask the symptoms a lot of times with that sort of a treatment plan, but that's not what this is. This is, you're going to get fitted for an orthotic. Here's what's wrong. Here's how we can fix it.
Right.
Here's what I have to do as in Dr. Insolera, and here's what you have to do as a patient. And we're about to start a journey. And
that journey isn't always a smooth asphalt road. There's some bumps in that journey because muscles don't respond the way, I mean, they're not going to respond 100%. Muscles have adhesions. Muscles have deficiencies through time. What we're doing is we're getting rid of that through function and through measure. I cannot run that office without being able to measure your muscles. That's impossible because I need to see just where the deficiencies are and how we can change that. And that's what the orthotic does. It's one on the lower. It's pretty clear looking. I mean, mostly you can't see it, but it does change the way you put your teeth together. And that changes the muscle range of motion and makes your muscles more powerful.
You really get to the point where you hate not having it in.
That's how I know people are wearing it, because I ask them, what happens when you take this out to clean? And they go, usually they'll say, I really don't like it out because it just doesn't feel right anymore. I need to keep it in for the support.
I bite my lip.
Yeah. It's exactly when I was doing, hey, I did this with me. I cured me. I was biting, it was always the right corner of my lip. But then, of course, as you keep going, that goes away. So it's a transition.
And this first step, right before you get into the treatment, that really becomes resource or exhibit A as you start to make the journey. Then there's months later, or however the particular person's treatment plan rolls out, these same measurements and x-rays and things are taken, and then there's an A-B comparison.
Yep.
You were here, and now you're here.
Well, we always do that. And that's because we can measure, and we can. The other thing that we measure is range of motion. So we'll take a measure between your top and bottom teeth every time you come in as well. And when people first come in, a lot of times they don't have a very good range of motion. Normal range of motion for anyone should be 45 millimeters to 55. Hey, I've had kids in that open 19 millimeters. That's terrible. I've had adults that open 15 or 10 millimeters. Again, terrible. And, they get all kinds of stories that their jaw's too small or this or that, the other thing. All I know is that when we do the right thing, do the right measure, those same people can open 45, 55 when we're done. And we don't need to do anything more than, like I said, measure and put the appropriate appliance.
And the click goes away.
Well, the click isn't that. If we want to talk about that, we can talk about that. The click is it's usually in front of the trajectory of the condyle, so that when you open, you click on, but when you bite, you click off and the jaw goes further back. So basically, as you provide the right position, you're providing the condyle with the right position, and the disc itself should be where it ought to be. But to tell you the truth, and this is true too, the orthotic creates the position and creates the support, because that condyle, the disc, has been tossed out of its moorings, if you will. So it's not on the head of the condyle, and it's very difficult to stay there. But with the orthotic in position and the support that it gives, we get the right position because it is the right position. It's measured. But you can get a click once in a while. But it doesn't mean the jaw's in the wrong position, okay, because we've already x-rayed that or tomographed that. So even with an orthotic, sometimes there is that click because sometimes that condyle gets in the way. It does. But if you're in the right position, you won't go too far back, you won't go too far up, and the muscles don't lose their range of motion. So it's okay.
And so as people come in and then they get their consultation, and you're straight up with it. The thing that I can't emphasize enough is how straight up you are. If somebody comes in and they don't have what they think they have, you're like, I can't help you.
Well, sure. I mean, I don't hide anything, and there's nothing to hide. I mean, it's all measure. So if I didn't think this was connected, I would tell you. But when you see the jaw in the wrong place and you see the forward head posture and the jaw in the wrong place, they're connected. That you can't disconnect that. I mean, you just can't. And forward head posture means It's not forward head posture symmetrically. It never is. Your body doesn't work symmetrically. It's always in an asymmetric manner. So one shoulder's always higher, one hip's always higher. We talked about that a bit. One leg's always shorter. So, but it's the same thing with your bite. Your each angle of your jaw is different. So when we take these X-rays, you'll see that the left side might be higher, the right side might be higher. So it's offset. The beauty of the orthotic is it changes the playing field and makes it equal.
People listening, when you get to his office, you're starting to be evaluated before you even walk all the way back to the room.
I can't help it.
He'll know that when you walked, your shoulders were here, your leg was here.
I can't help it. As a matter of fact, I've gotten that from one of my PTs, who we might be talking to at some point, and she just took a little trip, and she says, "I can't believe this. I usually look at gaits and the way people walk." She says, "And now I'm looking at forward head posture and the way their shoulders are." And so she just texted me that, and I was like, "Good, we're on the right track." No, we've done lots of cases together, and she's excellent. We go over cases usually on a weekend when there's no patients, and we can devote some time to each case. Everybody's different.
And there is a physical therapy component to the journey.
There has to be.
Yep.
If there isn't, if you're not going to do, if you're not going to do a physical therapy or a postural component, I'll go to that point. If you're properly, then why are we doing this? Okay. So my question to any patient is, if you're not doing that properly, then, well, the way we need to, because I'll coach you through it, and I'll coach any provider that wants to understand what we want through it. But you have to make that effort, okay? Because that's how you get cured. That's how we clean up these inadequacies in posture that we see. So the patient's very much involved in their own treatment. And
it's the only way it can be.
It's the only way it can be in my office anyway. But you're right. I mean, ideally, that's the way it should be. But we've been kind of, I don't want to get crazy with the medicine stuff, but you're right. When you take a pill, you expect to get better. When you take this, you expect to get better. But your body doesn't work that way when you're dealing with muscle and bone, particularly over time, and the changes that occur over time, because now we have to undo changes over time and change it and create function where there's dysfunction. And then we have to be consistent. And the word consistent is over time. And there shouldn't be any deviation from that. So.
And it's weird because maybe you can put it in perspective, but for me, that was very different. When the first time I met with you and then we talked about that sort of stuff, I was like, oh, wow, I've never really gotten homework when I go to a doctor. And I do think that's something that's very much so different in this process, that you are actively involved.
I'm a nudge. I tell them up front, I'm a nudge, and you will understand that when you come in for your office visit, because I'll look what you've been doing. We'll talk about it. It'll all be good. I'll be remeasuring. I measure posture. I wouldn't say every visit, but I measure your posture. Every 2 or 3 visits, we check that out. And we do a new C-spine on the neck to make sure that's working right. And we always check the bite. We always check the orthotic.
Yeah, you check the bite with that black paper. It takes me about 4 toothbrushes to get it off of my orthotic.
I try and get that off, but it's some kind of vegetable deal. But it does. So we can see it because and the whole reason behind that, it's called articulating paper. So when you're biting on it, why are we looking at it? Because your bite's changing as we're progressing, and I'm looking for points of change, if you will. And when it changes, it's because the lower jaw is changing in such a way that its position to the upper is slightly askew. So I have to take those deflections off so your bite is true. And that's what that's all about. And so that's why you need to come in every month or so because you're changing. You can't expect muscle to be consistent and working properly without change, particularly since it's never worked properly before. That's the real key that people need to get. It's never worked properly before. And I always tell people when they get their orthotic, which is designed to be functional for you at that very moment, they should go out and celebrate because it's really the first time in your life you've functioned because you've never functioned.
And that goes back to the stuff we talked about in podcast 1 about it is genetic.
Yeah. From what I can see in my office, in my records, I just had a family of 3 in the office. They all look the same. They all have the same bite. It's all the same. So you can see it. I mean, you can see what's going on. It's as plain as, I don't know how to put it. It's just obvious for me, and I've been doing this so long. You can see the face. If you think of a face as a tent, okay, and so you've got a tent and it needs a 6-foot pole, but your face is showing me a 4-foot pole. What does that mean? There are certain parts of your face that'll be sagging, certain parts of your face that'll be kind of pouting and maybe even a little swollen on the angles of the jaw, because when muscle works short, it can swell. And so you'll see that too. And you'll see the facial asymmetries. One part of the jaw might be flatter and the other part will be more convex, flat, convex, because of the dissimilarity of the height of the back teeth. The left side might be different than the right. Well, it will be different. But like I said, the orthotic changes that. It changes the playing field and makes it symmetrical.
And it's also different to me in this process that I've always been a person that's, even when I try to coach somebody in radio, like a lot of times when they say a break on the radio, I have, and I want to work on them, what they stumbled on or what words they didn't need or word economy and things like that. I have them write it out.
Okay.
Right. So they're involving another sense, right? They're not just saying it.
That's a good point.
Now they're seeing it and things like that. And one of the things I think about what's going on with me through this journey with you is you feel it, you see it, you hear it. And I think the X-rays and all of that stuff are part of that. Like you become more involved in what's really,
you might even
it's not voodoo.
You might even dream it.
Yeah. Yeah, it's not voodoo though. You can see what's going on.
Well, that's ironic you said that, and I think we said that last time. Is when my first lecture for TMJ, I remember the oral surgeon guy. I told him that I was going to a TMJ lecture for 2 days, and he said, "That's just a lot of voodoo." I'll never forget that, and that was so many years ago. And at first, when I first saw what I saw, I had no idea what they were showing me because it didn't involve teeth right away. I didn't see a mouth. I saw spines. Mm-hmm. These people were actively changing the shape of people with curves in their spines and making them right when the bites changed. Yeah, it's you have to search for the answers. Fortunately, now it's more than 30 years later. There are other people that can help. I kind of value myself as one of these people. But all the answers that I've gotten, I had to search for, I had to travel for, I had to extract and then make my own format, if you will. And now that's not necessarily the way you have to go because we've got proven formats that work, and I consider mine one of the proven formats.
Now, when you talk about going to seminars and sessions and things like that
every month
around the nation,
yep,
meeting with like-minded people like yourself.
Yep. The problem is coming back home because you're the only one that knows what you know. And now you have to espouse it. You have to live it. It's not just necessary to talk like we're doing now. It's necessary to walk the walk, not just talk. And that's what you have to do. And it's not, it wasn't. I'm not trying to get too crazy, but it wasn't the easiest road in the world because when it's not the total mainstream deal, then it's harder to make people understand. But the more active cases you have, the more successful cases you have, the more documentation you have, the more confidence you get, of course, and the more that transcends into your conversation with your patients so that they understand. This guy understands, not only understands, but believes in it, and here's proof that it works. And that's why the following is increased, and it's been real good because the patients understand that it does work. This isn't just something that I thought about 35 years ago.
It has to be satisfying to see it has evolved, though.
Wow.
Satisfying and frustrating?
Absolutely, because like I said, it should be. I think it should be as mainstream as could be, but we're still searching for that. It's still going to. It probably won't happen while I'm around, maybe, but certainly I would say in the next. I don't even want to predict, but let's say the next 10, 15 years, things will change even more.
Well, and I think some of the stuff, the yoga and the physical therapy and things like that you that you have in your treatment, I think the world has become more open to those concepts as well.
Certainly.
So that I believe when you reverse engineer it, it kind of helps what you're working with too.
You have to set the environment up. So the yoga and the swimming and the stuff like that and the PT, all of that stuff is very necessary and very helpful. Again, but the stage is set with the disconnect that nobody seems to get until I bring it up. You've got to function 5,000 times a day. And I didn't make that up. That's just the way it is. And if you take an anatomy book and care to look at your head and neck and look at the muscles connection, you'll be astounded to see that they all connect to each other. So if you're 5,000 times a day in the wrong place, I don't care what you do for posture for the rest. You can go wherever you want for the rest of your life. You can't be stable because 5,000 times a day you're creating instability into the very posture that you're trying to stabilize. So you have to have it. You have to have the table set as well.
And the consultation is almost like a science lesson because when you're showing, I wasn't aware of the muscles holding, a bone that just floated
good for you.
In your neck and things like that when I first met with you. And I'm like, that's crazy when I'm thinking about it. Then I look at my own x-ray and you're like, there it is. And I'm like, ah.
Yeah, and you can pretty much, it's well, let's put it this way. I had a person in my office that had CPR done on them, and we had treated them for TMJ and cleaned it up. So I had the ending x-rays. And after she got treated for CPR for an incident, she couldn't breathe or speak or swallow. She was in the ER twice. They scoped her. They told her vocal cords were paralyzed, and they were going to send her to a speech therapist. And I finally said, get in and let me take an x-ray. And when we took the x-ray, the hyoid bone was right up against the mandible where it shouldn't be.
Okay.
It's because when we were done, it was down below by C3, C4. But here it was by C1, C2, which tells me right away this is a trauma incident, and the muscles are reacting adversely and creating a problem. So what do we have to do? I have to put her back on the computer, measure the right position for her new muscles that have been injured, put an orthotic in again, and as soon as I put that orthotic in, all that stuff went away. All that stuff went away. It's remarkable. And then she said, well, my husband wasn't too happy because now I'm talking to him again. So I was like, oh, well, at least you're feeling good. But the orthotic created the environment to drop that hyoid bone because all those muscles are attached to it, 20 of them. And that's how your windpipe stays open. And because it's conveniently or strategically is the right word, placed right here, right in front. It's strategically placed there. It will control your cervical vertebrae, which also controls the back end of the windpipe, which also controls what your head weighs, because if it's back over your spine, it's 12 to 15 pounds. If it's in front with the forward head posture, not only are you not breathing right, but your head weighs 30 to 40 pounds, and you're using accessory muscles of your upper chest and neck, creating more forward head and more problems and more swallow problems possibly. So it's if you just connect the dots, it's really not rocket science. It's just common sense. And just look in an anatomy book. Not that people want to look in an anatomy book, but I do that. And
you took care of that for us.
And I still do it because I still enjoy doing it and still watch. I like watching how these muscles interact. And it's a nice refresher just in case. But yeah, no, it's so dynamic, and of course I'm living it every day. So anything I look at, I can apply.
And that is the difference working with you on this is you do take the time to educate people on what you're doing and why. Oh, don't worry, we're going to take care of it.
Anything I know, I make sure people understand the way I know it, and I try to make it so that if I can understand it, anyone should be able to understand it, because it doesn't have to be a high sophisticated level. You don't have to put a giant medical term on it. So if you have a dystonia, for instance, okay, a dystonia simply means that the muscles are contracting and twitching and whatever. We had that with that lady that was in Dubuque, and we got rid of that dystonia, and that dystonia lasted 15 years before we put an orthotic in. And in 1 week, according to the PT, because she saw her in a week, and she called me and she said, I'm calling you because she doesn't have that. It's gone. I mean, her muscles are still somewhat weak, but she doesn't have what she had. And I said, well, it's a week, but it's 5,000 times a day times 7. So it's 35,000 times that she got function, and she was 43, that she never had before in 38 years from age 5. So,
and just when you talk about some of those cases, like somebody that can only open their mouth 10 to 15 instead of 40, the burden that becomes daily, trying to eat.
well,
Getting a spoonful of something in your mouth has to be impossible.
You can't get a spoon in at 10. Basically, you can't. So I just tell them, don't chew at this point. You can't. But once we can get an orthotic in, then I don't care what you chew. I think I mentioned that again. The orthotic protects the joint, protects the muscles, and so you could get the chewiest thing in the world. Sometimes I tell the patient, you can chew nails. I don't really care. With an orthotic in your mouth, it doesn't matter, because you're just on the wrong place, and you're just duplicating function through multiplication of the muscles working.
Is it fair to say you're starting to heal yourself by chewing?
Absolutely. Of course, yeah. You're creating more vascularity. You're creating more blood flow. You're creating more oxygen. You're getting rid of lactic acid. The lactic acids are the trigger points that if you press on a jaw, press on a muscle, you go, whoa, I didn't know that hurt like that. They're called latent trigger points. And that's because these muscles are working so short and dysfunctionally, they pool acid in the muscles. And when you press, you're literally pressing on some acid, which really hurts.
So I'm going to have an extra piece of pizza tonight and tell my wife that you need me to.
You could do it. It's all therapeutic. It's all therapeutic, and it's all good. Yeah. I just had a lady that brought her daughter in for headaches and neck pain and face pain and stuff, and I'm explaining everything. And the lady still, she was in the chair, but we were at a distance, and she had her mask on. And all our rooms are sanitized, 100% sanitized air. But I asked her to just take her mask off for a second so I could take a look. And of course, the mom's the daughter's the mom. And so when we were talking, and this was a cure consult, and the daughter said, the mom goes, well, we're going to have to get that new patient exam, but I think it's going to be both of us because she has the same. I said, look at your mom, because you will have those symptoms in that severity 20, 30, whatever it is, 30 years later, because it's just the multiplication of dysfunction.
So catch it early.
Catch it early so you can, have more fun with your life.
Right.
Why have all this stuff that we see? I mean, this is basically, I don't know whether I don't call it, I don't know what it was, an introspection or a look into the future. When I did, like I said, worked in nursing homes, I could see what could happen with forward head, because people don't have a problem walking. People have a problem swallowing. People have a problem breathing. We want to kind of create an environment where that wouldn't necessarily be there anymore. So as you get older, it shouldn't be there. Let's put it that way. Hopefully, it shouldn't be there if we're functioning.
So in our next episode, we go from the Cure Consult to
the Cure Consult to the TMJ exam, which again we do tomography X-rays, which is joint X-rays, and we do postural check. We do range of motion exercise, range of motion measures, and we look into the mouth. We actually do what's called a Malin Patty, and a Malin Patty is looking at the airway. The person just opens their mouth. They don't stick their tongue out. We just look at the mouth and see what you see. And if you can see a uvula and you can see on either side of the uvula, black space, you're in pretty good shape. But as you see less and less of that, then your reading is worse, and you might think that this person either has a snoring or an apnea issue. So that's one way of looking. If I could digress at this point with that, I was in a nursing home at one point to take an impression of a man that was lying in bed, and his mouth was open, and I happened to be able to check his mouth out, and I could see that I couldn't see his uvula, and I couldn't see his airway, and I only saw his palate and tongue. So I called the director of nurses in, I called the head social worker in, and I showed them what I was seeing. And I wanted them to tell me, and they said, well, we just see a tongue and a palate. I said, right, but there's no airway. So what was this man in for? And they said a stroke. And I said, have you checked him for sleep apnea or sleep problems? And they hadn't done that. And so I said, I would suggest you do that right away because him not getting air might subject him to some more severe problems. And then when I came back to the nursing home, the nurse said, we did what you said, Doc, and we caught it. Thanks. Because they found out that he was deficient and that creates all kinds of bad problems as you get older.
Right.
So, yeah.
And it just compounds and compounds and compounds.
That's really what we're talking about. We're just sort of going back and forth and saying this. We're saying the same thing in a different way. That's all. But that's what I see. You just take something and run it through 20, 30, 40, 50, 60 years. I've just had the benefit of being around seeing it and putting it 2 and 2 together.
And there'll be plenty of videos, links, photos, and other assets that illustrate what we've discussed on this podcast on the page on the website.
Yeah.
All right. Thank you.
Thank you. Appreciate it.